Wonderful. Thank you so very much for joining our discussion today on the business case for faith-based health systems over the next decade, hosted by Christian Connections for International Health, or CCIH. Good morning, good afternoon, and good evening to everyone. There are both French and Spanish interpreters today for today's webinar. Click at the bottom of the screen for the French or Spanish translations. When making this selection, you can choose original sound to mute the original sound. My name is Janelle Williams, and I serve as Director of Programs for Global Health Action, and I serve also as the co-chair for the Christian Connections for International Health's Leadership and Governance Working Group. If you are new to Christian Connections for International Health, we are an international network of approximately 115 Christian organizations and 15 affiliated partners, as well as a few hundred individual members, all working in over 90 countries. CCIH's mission is to promote health and wholeness from a Christian perspective and provides opportunities for capacity building, networking, fellowship, and advocacy. Now we'll move on to our annual conference. Our annual conference is coming up next June in the next few weeks. The theme is Loving Our Neighbor, a Christian response to a changing world. We'll explore our response as Christians to the many challenges and new opportunities we experience today in global health. There will be simultaneous interpretation into French and Spanish. We hope that you'll join us. There is a link in the chat for more information. On to this webinar. This webinar was organized by the CCIH Leadership and Governance Working Group. You can learn more about the working group and our charter on the CCIH website and through a link provided also in the chat. The Leadership and Governance Group is a very powerful group of folks working within this sphere. And what we're excited to do today is I have also, along with us within this webinar, is my other co-chair, and that's Zimbabwe. And we'll learn more and talk a little bit more about leadership and governance and all that's contained. We invite you to join us. So to give you a bit of understanding regarding the webinar and what you can expect today, here are a few housekeeping comments. Today we will hear briefly from 3 experts who have a lot of experience with faith-based health actors. We'll ask them a few questions and then open it up to Q&A from you. Please put the questions and your questions in the Q&A box. Recording will be shared on CCIH, and you'll find that under the Webinar Recordings tab. Today we will hear from Sidile-Chitimbire, Executive Director of the Zimbabwe Association of Church-Related Hospitals. We'll hear from Dr. Priya, the General Secretary of the Christian Medical Association of India, and we'll hear from Jean Poyce, the Senior Public-Private Partnership Advisor for the USAID in Tanzania. Again, we'll ask you to type your questions into the Q&A box on Zoom so that we can answer as many as we can. Please do not use the chat for questions for the speakers. A little bit about me. My name is Janelle Williams, and again, I serve as Director of Programs at Global Health Action. My work is around developing programs, partnerships to strengthen health systems and community systems in low and middle income countries and historically disadvantaged communities in high income countries through comprehensive training, technical assistance, research, and advocacy. My passion is in health equity and certainly ensuring that health planning, community engagement, leadership management, and governance are situated. I'm currently working on my doctorate in public health at the Indiana University, Purdue University at Illinois, at Indianapolis. So I'd like to move on to introducing V. Affectionately known as V. She is the Executive Director of the Zimbabwe Association of Church-Related Hospitals and has over 30 years of experience in the health sector. V specializes in management planning, appraisal, and reform of the health sector, including systems analysis, change management, institutional training, strengthening, and project management. And now on to V. V, thank you for being here today. Thank you so much for being a part of this panel. And if we can move the slide on, we'd like to start with V's presentation. Thank you.
Thank you, Janelle. Good afternoon, good morning, everyone from all parts of the world. I'm just going to share with you the governance issues within the Church Health Associations. This will be a sampling of what is happening in the Church Health Associations across the region, taking a cue of some of the issues which we are experiencing as such in Zimbabwe. Next slide. Just to give you a background of ZACH, we are the medical arm of churches in Zimbabwe. So Zimbabwe's population is 15 million plus, and with the rural population representing 70%. We're a registered voluntary organization, not for profit, and our operationals is to support mission health institutions from all denominations. Hence, our operation is ecumenical. Our setting is rural and hard to reach areas. Our membership, 135. In terms of health service delivery, we represent 68% in rural Zimbabwe and 45 nationally based on bed capacity. 22 mission health facilities are designated hospitals where government has no district hospitals, and also nurse training schools for the human resource development for the country. We have presence in 68 districts of Zimbabwe and 10 provinces of Zimbabwe. We have a well-defined leadership and governance structure, which composes the Zimbabwe heads of Christian denominations, who are the owners of all mission health facilities. We have a management board, which has an oversight over the ZACH Secretariat, and we have a board of trustees who manage the pension fund for mission health workers, and the secretariat, which is headed by myself. So the map below on the left of your screen shows where we are dotted. So we're all over the country. Where we're not represented, these are national parks and other areas. So based on the WHO study, you can see on the right, the contribution of church health facilities in the region. So you can see that some of them are almost 50%, and the minimum being 30% or so. Next slide. So our business case is such, our revenue stream is 96% from external partners, 2% from ZACH main, that means the funds which we generate as an organization, 2% from small grants. So the total revenue per year is 6 million plus, and our projects run for 5 years and some of them for 3 years. And if you look at the national grant which we get from government as such, we're getting 7.9, which then funds mission health facilities 100% in terms of salaries, recurrent expenditure, and capital investment. Other revenues, other benefits which we have as such, we're exempted from paying duty tax for donations on any donations and other hospital importations. We have a strong ecumenism and strong leadership in terms of representation. We are a non-actor, which is meaning that we represent partner investment and also in health security, and we play a major role in complementing the government of Zimbabwe in health. We look at sustainability and issues. We are very sustainable in terms of our operations because we own the institutions and we are local and we are impact driven, meaning that we need to make sure that we reach our populations and make sure that they have good health. We are donor-driven, which is also performance-related. So if you look at the chart, it shows you where we get most of our funding, and this is this setup in most CHARs in the region, with a few CHARs actually generating their own income. So the question is, if the partners decide to pull out, how can we sustain ourselves in terms of financial resources as countries? Next slide. So we do have gaps and challenges. I usually refer to the picture shown there that I'm a human being, but I'm expected to be a superwoman in terms of management. So we find that there are so many challenges which CHARs have. We look at business and operational dynamics, where we're looking in the countries where we're operating from. There's conflict, there's economic challenges, there's natural disasters and so forth. So we need to be able to survive within those areas. We have stressed economy, particularly in our country, and high inflation, which then affects our way of doing business as managers, and also trying to stretch the dollar to make sure that we provide the services people want. We look at issues of health financing, which also affect us as countries. Zimbabwe currently is said to be at 20% of Abuja. This is attributed more to the input from the COVID-19 pandemic. We're far less than that, but this is what they are reporting internally. We also have to look at the health legal framework, where we're looking at constitutions, regulations, and law. And in most countries, we find that as NGOs were looked at with a microscopic lens to make sure that we remain within our mandate within countries we're operating from. And also we look at the perception of Fbos, meaning the capacity and experience. This is where most of our CHARs are affected due to the fact that when we apply for resources, they look at our capacity. So there's issues which we need to look at in terms of making sure that our institutions have the right systems for us to be in quote capacitated. Also need to look at donor management and compliance, which for those donors, countries which are getting large sums from donors, these are some of the pitfalls if we're not compliant, and also looking at how donors expect us to operate. Then we look at sector leadership and the sector split. This is this was shown mainly during the COVID pandemic. We realized that we're not working in collaboration as sectors. Even CHARs and our institutions were running around looking for resources, which was splitting us. So if we work in collaboration, we bring more brains and more knowledge and expertise so that we can succeed. Also, we're having resource mobilization competition as CHARs, whereby we find that we compete in terms of proposal writing with larger international partner organization. So it's like comparing apples and grapes. CHARs being the grapes, because the chances of us getting large donations are very slim. So these are some of the issues in terms of leadership which we should be looking at and putting at the back of our minds. Then when you move to facility levels.
I don't know if you can hear me.
Yes.
I think what we can do is if we can kind of pause on this, because we're running with time, and I think we can follow up with some of the questions during the Q&A so that we can move to the next speaker. Would that be okay?
Okay, great. That's fine.
Fantastic.
Thank you.
Thank you so very much. I do realize that we, sort of closed out with you sharing about, sort of really looking at it from a larger national perspective. And I think we can get down to the details of what does this look like at the facility level. And that's really where the rubber hits the road. So I'm looking forward to us continuing to to speak, to inquire, and to have more conversation about that. Thank you so much, V. Our next panelist is Dr. Priya John, who is the General Secretary of the Christian Medical Association of India, and a position that she's held since July 2019. Prior to that role, Priya worked for the CMAI in the Community Health Department and worked in palliative medicine in New Delhi for 3 years before coming to CMAI. Thank you so much, Dr. John. We're so appreciative of you being here today and look forward to your presentation and our discussion with you. Please, Dr. John, go right ahead.
Thank you very much, Janelle. And I bring greetings from the Christian Medical Association of India based in New Delhi. And thank you very much, CCIH, for this wonderful opportunity to share a few thoughts on the business case for faith-based health systems, especially over the next decade and coming from the Indian context. May I have the next slide, please? Yeah. So a simple overview of the context of healthcare in India. 80 to 90% of people say religion is important, and it is a daily part of their lives. So the case for faith-based starts here. With India's public health expenditure only at a 1.2 of its GDP, we are very much insufficient in supplying adequate public health funded healthcare facilities for our communities, as well as having adequate staffing at the public health facilities. Just like we said, 70% of our medical care, we do have a huge rural population. Okay, sorry. We have a huge rural population, around 70%, and most of that, the 70% of the healthcare facilities is given by the private sector. Now, the number of hospitals, which is not for profit, and that is where many of our faith-based organizations come, they are about 10% of all the hospitals in our country. That is about 13% of all the beds. And knowing our country's population, that is a big number. Now, the other reason why a faith-based organization is important is because we do focus on the poor and the marginalized. And in our country, 21% of individuals do fall below the poverty line. Now, what is the case for an FBO given this situation in our country? Through the years, through the decades, through the centuries, FBOs have always consistently stepped in the gap and ensured that cases, areas where nobody else was willing to go, they were there. Examples are leprosy, HIV, disabled, and vulnerable. Faith-based organizations are integral for marginalized, especially given the caste system in our country. We do not work in parallel structures. We do work with and support the existing structures in healthcare. And the contribution of FBOs to education, healthcare, and charity is very evident. May I have the next slide, please? As a community health association in our country, we have 274 organizations, as you can see on the map, and 60% of them are engaged in community outreach services. About 64, in the last point, are having any kind of community like service, for example, just a mobile clinic. Many of them are secondary care facilities. But what I want to draw your attention to is that we serve special populations, and this comes back to the gaps that FBOs fill. The elderly, the Dalit population, which is a caste issue, the tribal population, slum dwellers, and migrants. May I have the next slide, please? The challenges that we face now as FBOs. Now, I understand that there are challenges for us as a health association, but also for our facilities, just like we was trying to distinguish. Now, for us, on the whole, the government commitment to public health through partnerships is a concern, not only because it might end up having parallel structures to what we are already providing, but also the partnerships are not easy and involve a lot of criteria as well as a lot of documentation. Health insurance by the central and state government, that's a good thing, but it also does not give quick and adequate reimbursements to our facilities. Foreign funding curbs. Yes, we are a little different from Zimbabwe. We are not totally dependent on external funding. It is more about patient footfall, but these foreign funding curbs do influence the capital expenditures that our hospital need to grow, to expand. So that would be an issue. Corporate institutions foray into healthcare. This is another area where we have the private for-profit sectors coming into the poor and rural parts of the country as competition. Governance, church-owned versus the healthcare professional run. Human resource, which is important because a champion is needed with long-term and who are capable. May I have the next slide, please? So is there a continuing relevance? The answer is yes, for all Fbos. And why? Because it is his mandate to serve the poor. The communities, through the generations, we have got a legacy of trustworthiness, and that is something we will build on. Healthcare is compassionate, ethical, and affordable. Now, every hospital which is doing well has a God-sent champion and motivated staff. And this is something that we will, as a CHA, we will build on as in leadership building. And then we have something called the hospital that is, there will always be a gap to fill, and that is what an Fbo's role is, elderly care, palliative care, and the others. We are innovating ourselves given the lockdown and the pandemic, which saw a huge explosion of innovations, and that is going to be done. And of course, the Christian presence and the showing of love of Christ will always be relevant. And that is why we go ahead with the business case for Fbos, ensuring that we do not ignore the poor and the marginalized and keep his mandate in picture. So thank you, Janelle. I will end here and I will be happy to take questions later.
Absolutely. Thank you so much, Priya. I think what you shared is so powerful in the sense that, one, recognizing the target audience and in some ways those left behind. And so thank you for sharing some of those key stats and this presentation, and I look forward to us speaking more in the future discussion. Finally, I'd like to introduce Jean Poyce. Jean is the Senior Public-Private Partnership Advisor at USAID Tanzania. Jean has been with USAID Tanzania for 13 years, responsible for designing and overseeing the implementation of private health sector projects. Prior to this, he implemented USAID-funded projects for 12 years focused on institutional capacity building, human resource development, and private sector engagement. Jean, welcome to our panel. Please begin your presentation. Thank you.
Thank you, Janelle. Slide, please. Thank you. We share the same situation with India and Zimbabwe in that it seems that all of our hospitals are fairly dependent. In this case, we were dependent on the government. We had good service level agreements with the government, but in March 2019, the Magufuli administration announced that they were going to end the service level agreements and that they were going to construct 67 new hospitals, some of which were very close to existing CSSC hospitals. So that was the impetus. We could either stay on that path and move forward and try a new direction. Next slide. I'm not going to go to the details of the study or the video clip. The references are there, but me and my colleagues discovered this study at Harvard University, very convincing. Basically, after really good studies, they compared control hospitals to those that shifted from nonprofit to for-profit and found out that they still serve the poor and the marginalized and the minorities. And that was very convincing to all of us. It's particularly important for CSSC because one of the core values is the giving Christian hope to the poor people and serving them. That is a core value that is unshakable. Secondly, they represent more than 40% of all the hospitals in Tanzania. So the business case is there. If they fail, the national health system goes. But they are also recognized as a hospital that generally outperforms the public hospitals, and they're very open to all the other communities, faith communities, and socioeconomic groups. Over, next. One of the things that we're dealing with our project is they're starting to show some real moves away from dependence. We're moving toward market-based rather than donor dependent models. Just a few examples. Figure 1 shows where they worked in a pharmacy at a hospital, and the hospital was referring patients to purchase medicines at other pharmacies because they didn't have it in stock. As a result, they were losing revenue. So that lost revenue, this graph shows that all of a sudden the outgoing requests for pharmaceutical declined, and they were taking more of the revenue in at their hospital at the same time. Also in figure 2, by working with the hospital, their insurance claims and revenue are going up. And so they're looking at quick wins, and they're coming in with pharmacy, insurance. I can give stories around staffing as well. We're short of time. I won't go into that right now. They're looking at business opportunities. That is, well, how can we segment the market, provide fast track services for those who can pay, private wards for those who can pay, specialized services for those who can use them, are willing to pay. That then cross-subsidizes serving the poor. Again, back to the original proposition from Harvard University, you can do your financial management better and still achieve what you want to do. Another area we're working is changing the composition of the health facility governing boards, making sure we have people who understand the business aspects of it. And it calls for some reorientation. So things are going very, very well. And I think there's a way out for all of us so we can reduce our dependency, either on governments or donors. Over, next. And so I won't go through all of this, but we have a fairly large activity. At this juncture, we're really focusing on the Tanzania Episcopal Conference, that is the Catholic Church, because it is a structure that really permeates throughout the country. But CSSC also represents Christian Council of Tanzania, which, as you can see, has a number of denominations there as well. But what we're hoping at working on with the Tanzania Episcopal Conference and their churches, that the lessons being learned, as I just showed in the previous slide, we can share them with others throughout the Christian community and upgrade their hospitals too. So the bottom line is we can serve the poor of all faiths. We can do that by being financially more responsible and more self-sufficient. Thank you. Next slide. Asante-san. Thank you.
Thank you so much, Gene. Thank you so much for walking us through just a really high overview of what's happening in Tanzania. And I think we'll definitely come back to speaking a bit more certainly about the governance, the leadership, and certainly looking at that sort of the shift in thinking about how to run the health facilities. And so thank you so much. I want to say thank you to all of our speakers. First of all, each leader here is quite a tremendous example and a tremendous leader. And so again, thank you so much for your presentations. As we move forward, before we open it up to the group questions, I do have a few questions for each of you. And they're a bit long in narrative, but I will try to get through them. The first is really looking at leadership and governance. And so we all know strong leadership and good governance are cited as the critical levers for addressing health and well-being of populations. Yet governments in many LMICs have shared that these levers have been elusive and challenging. However, many faith-based health systems are known for sound, honest management, technical excellence, and adaptive programs such as community outreach. Can you all speak to this? What makes faith-based health systems different? And if you can speak to it from your context, that will be absolutely phenomenal.
Let me just come on in. I don't know the order here, but I'll just continue with my theme before. I think the biggest change that we have to make is start looking at market-based models for making keeping our hospitals self-reliant financially, managerially, rather than being donor dependent and relying on donor goodness, whether it be from the outside or the governments themselves. We have to come for self-sufficiency, and it can be done. Over.
Beautiful. Thank you, Jean.
Janelle, may I?
Yes, please. Go right ahead, Priya.
The question was about governance. And for us, almost 80% of our 274 mission hospitals are owned by the church. So by default, if you look at the governing board of all our mission hospitals, they will have a ex officio member from the church as the chairperson. It's not just a member of the board, but most often it will be the bishop as the chair of the governing board. Many times it's a plus minus situation. Cannot generalize the advantage or the disadvantage of that. But from our small study that we did in 2015-16, we found that the two main the important, factors that bring about good governance. The first one is you have diversity on your board. You have board members from different walks of life, like, legal people, financial people, different mission hospitals from different denominations. The diversity works well on a governance board. And the second is when the church is invested in its ministry of healing, which is, in health, healing, and wholeness, and they look at the hospital as their mandate, not as something to bring in the money. When that ownership of the healing ministry makes a big difference, and those hospitals do very well. So that's where the governance is important. Thank you.
Thank you, Priya. Thank you. Thank you, Jean. V?
Thank you. Thank you so much. I think, first of all, we need to have constitutions within churches or within our mission institutions, which then will guide us in terms of governance and also build onto the relationships which we have with our church leadership, and also looking at Ministry of Health leadership. Because if you realize this cascade is that we are serving two masters at once, the church leadership and then the government leadership. So it is critical that we know our mandates and also look at our strategic setup within the organization in terms of our obligations, in terms of our strategic plan, and also to look at the people we serve. Because as Christians, we are following the teaching of our Lord Jesus Christ, where we had to teach, heal. So our approach is holistic. So it's critical that we remain within our mandate. We have the constitutions which will guide us. We also have a strong boards at both churches and at various institutions, whereby they will make sure that they have an oversight to make sure that our mandates are met and that we implement as we do. So it's very critical. And also when we bring in people into these setups, we need people with a common mission so that we can drive our processes. So it is critical that we bring people who are Christians, who have got Christian values, but we also bring in the expertise to make sure that we sustain our organizations. Thank you.
Thank you so much, V. And it's pretty impressive. I think, there's a couple of things that I just pulled from that. So one, in order to look towards sustainability, there's got to be the diversity within the leadership, within the governing body, and there's got to be systems in place. And then I think when we talk about faith-based health systems and what's the difference, right? It's that it's faith-based. And so having, this additional component of healing, this additional investment, right, of the heart is something that I think is prime, right? And I think that's what you're really sort of leading to as well, Priya, when you share that. So that becomes really, really helpful and important. And I think, as you said, when there is that investment by the churches, that becomes really, really helpful. So my second question to each of you is really looking at health equity and really looking at global health equity. And so, there's a list of global health practices that we know are colonial legacies, and there's a long list. Anything from the perpetuation of the inferior status of people and systems on the receiving end of global health services, coming from sponsors who give grants and build capacities to increase more channels for donor control, whether it's researchers who conduct research to instigate racial or ethnic disputes at the expense of the population that they study, to practitioners who deliver healthcare in a way that further cripples the local healthcare system and make the people more dependent on external help. Those practices are unfortunately really prevalent, as we know, in global health overall today. Experts, missions, scholars being sent to areas of extreme poverty, extreme resource scarcity, where no local leaders, local communities can sustain the projects once they leave. So that's a mouthful. Recognizing that not all faith-based health systems operate with the same model, tell me, what is the call to action here for faith-based health systems, leaders, and funders? Long, but I think good to set the stage for the responses.
Well, if I may, let me give you an example. We had a university for the United States fly in here with some MBA students who went to a hospital, and they found at that hospital they already had the drawings for a new maternity ward. Everything was laid out there. And their approach then was immediately go back to the United States and try to raise funds. Then they had a conversation with me and some of my other colleagues. And we said, have you costed out how much that's going to cost to equipment, for your health staff? And have you thought all these things through? And by the end of the day, they realized that, yes, we can have large visions, but we got to figure out how we can support that. Mm-hmm. And we can't rely on outside sources. So they had to rethink that process again. Instead of doing 4 floors, they would start with 1 floor. And as they would continue to improve their services, they could go for the next floor. So that kind of business thinking has to be there. And back to something that Priya said, she's so right. You need diversity. And she did mention that, sometimes the religious faith leaders are going to be the chair of the board. What we're finding through our intervention is once we start getting the idea of balancing the books and making sure that you don't have to depend on someone, they are more interested in the financial aspects than you can imagine. And they actually are asking more detailed questions than we ever thought they would ask. And probably it's not even the role of the board. They're getting so detailed. So I think that's a really radical transformation. And it doesn't mean that they left the faith, not whatsoever. They just realize you have to execute good financial responsibility. Over. Thank you.
Thank you,
James. Okay, Janelle, if I may. So the question is a loaded one, but let me just address, because I did have a look at the list of participants who were going to be listening to us. And I realized that there are Christian health associations here, there are non-governmental organizations here, as well as church organizations here. Now, if we look at our sustainability as a Christian health association, our sustainability has to come from the understanding that we are there to uplift our members. We are there to put them in the forefront. At the same time, now that is not going to make us sustainable, but what can make us sustainable are our various education programs and filling in the gaps as a national level organization. And that's where advocacy comes in. So when you talk about speaking up for those who cannot speak and addressing issues of the marginalized, of racism or casteism or however, there's so many issues which do not allow equity to become equity possible, then we are looking at us as CHAs to be that national voice of advocacy, of intervention, of bringing what is happening in the grassroots to the power, the corridors of power.
Correct.
That is one of our biggest important missions as a CHA. Now, the second thing is when you look at our institutions itself, the healthcare facilities which are actually doing the work. As CMA, you can see I've written, this is our vision statement, building a just and healthy society. But I don't do that. I do that with the members, and they're the ones at the grassroots. Now, for them to address your issue about equity, it has to be about what the community needs. It is about keeping the trust. It is about keeping the Christian presence in every area of need. Now, from maternal health care, it might shift to elderly care. Are we ready to make that transition? Are we prepared? That importance. And then the whole idea about when we look at community outreach programs, it has to be something which involves social issues. That's why the NGOs, that's where they want to bring in the money, to look at a social determinant affecting health. So the NGOs like those kind of projects. Are we doing something on those lines for our community? Are we looking at their development, through small livelihood projects? Are we looking at their sustainability beyond the project? Because many times the project is there, it's really good, and then it disappears. Are we looking at equity in terms of networking with the local government and ensuring that there are inclusive services for every person who is marginalized in that? Because many times a project runs and we don't remember the marginal, the disabled, or the low caste, or whatever it is. There are many benefits that we need to bring to their tables. That is inclusion. And then, of course, continuing that whole thing with ensuring the sustainability of those projects. And of course, the church coming in, of being the presence in the community of compassion, of care, and of their mandate of health, healing, and wholeness. So I'm trying to bring the whole picture when it comes to equity. So yeah, thank you.
Thank you so much, Priya. That's so beautifully said. Thank you. V, I see you took your speaker.
Thank you. I think they've said a lot, but I think in terms of equity, I was looking at I talked about leadership split, and we saw that a lot during the COVID pandemic. I think in terms of country, because all of us serve under countries, we need to actually come up with sit around the table and bring the right people around the table in terms of health delivery, where we plan together, whether it's private, public sector, church institutions, and so forth. So it's that collaboration in terms of delivering these services, if we have to meet our national on global goals or national goals. Then when we come to CHARS ourselves as CHARS, I'm glad that we've got CCIH, we've got ACHAP, we've got all that. This can help us also to look in terms internally to say, as faith-based organization, how can we make sure that we remain sustainable and also mobilize resources to look internally and support ourselves without looking too much on external. Then we move down to the church's ownership. We find that sometimes, not in all aspects, that yes, the church health associations have been formed to facilitate the smooth running of churches in our countries, our organizations have been put to do that. But there's a disconnect in terms of the church leaders, in terms of their contribution towards their own institutions. A few of them can do that, but we find that the majority, they then expect the church to provide. So if I have to fundraise for 135 facilities and fundraise for projects which are streamlined, whether it's maternal health or HIV and so forth, it cannot reach everyone. So we need to look at how then can we create synergies amongst ourselves and also amongst the church leaders to also fundraise for their institutions so that the communities benefit. We are not for profit, hence we're not like schools which can raise funds and then they can use those funds to build their institutions. So there's that issue of collaboration, creation of synergies also on the ground, like what Jaya was saying, that the NGOs, community-based organization, we need to create synergies so that at least we do not duplicate our activities on the ground, but ride on those who are already doing something on the ground and direct them in the right direction. So it's a whole mix, but I feel that collaboration is very key, starting from national level up to the ground level, and the creation of synergies. That will then have us have strong sustainability structures within the country. Because we know some provinces are poor, others are good. So the issue of equity can then be balanced. Thank you.
Thank you so much, V. I mean, this conversation around sustainability is so significant. And, you know, I was looking at the chat, and you know, again, thank you all for your responses. There was a question saying then, well, what then is the business case for the faith-based health system? And I'll take a stab and really ask y'all's reaction. But I think each of you sort of, you know, really aligned to the fact, right? We know that healthy people, right, make healthy communities, make a healthy nation. We also know that healthy people have a direct connect, right, to healthier economies, and that fundamentally means that if you have a community, if you have populations that are distressed, populations that have lower health outcomes, then that impacts the ability of that nation to move forward, and that is a different perspective, right, than doing good for the good, right? And so I think what sounds to me is that what faith-based health systems do is doing things with a heart, right? Is providing that holistic approach to health, rooted in communities, rooted in daily lives of people, are not popping in and popping out for the most part. But that in and of itself allows for there to be a meeting of a need that the governments, for the most part of the nation, are not able to satisfy. And so I said a whole mouthful again, but I'd love to hear your reactions. If someone were to say, what is the business case for faith-based health systems, what would your response be?
I think it comes from what we call respectful care, and that respectful care comes from the belief in Christ and our responsibility to the poor. And in Tanzania, for example, the Christian hospitals serve the Muslim community because the Muslim community does not have many hospitals. So every day, people of other faiths are coming through that door, and no one is discriminated against whatsoever. And that is recognized. And I just had someone make a trip into a predominantly Muslim community where there was a CSSC hospital, and they said, everyone says we will go to that hospital as opposed to the public hospital. Mm-hmm. They have their business case because of respectful care. The only added addition I will put to that is they have to pay the bills at the end of the day. And they should be able to raise the funds internally, and they can. CSSC is coming up with very innovative, quick wins and they've only been operating for 2 years under this project. They can show it can be done. You can have both. As a Harvard study says, switching from nonprofit to profit does not mean you leave the poor. You don't have to. You can have it both. It's not binary. It's not this or that. It's both.
Wonderful.
Thank you.
Beautifully said. Thank you, Jean. Thank you.
Thank you, Janelle. So, and thank you, Jean, too. I think that was, I agree with Janelle, that was very well put, I must say. So just looking at what is the business case for FBOs, the first point is the poor will always be with us. That is important to note. The second is, now we have all moved on to an institutionalized model of care, where we have an institution and the patients come to us and we provide the care. And the care is ethical, the care is compassionate, it is trustworthy, and the community has no complaints in coming to our institutions. But now the business model needs to change a little bit, given the health concerns that are coming up. Now, what does that change? Will it be from an institutional service to a more community-based service, a home-based service? I believe in our country, that would be one business case for our FBOs. Moving out a little bit more to the communities, providing the care at the home, especially given the burden of elderly care, mental health, as well as a lot of rehabilitative care. Now, the second would be the business case. If you have committed committed individuals, both in the hospital as well as the church, you're set, because they will bring about a strategy, because it is his mandate and they are just following. They will bring about a business model which will sustain. And we have fantastic examples of that amongst our membership. The other business case is, now since we are providing for the poor, we may not always have the funds to make ends meet, like what Jean was also referring to. So we must look at cross-subsidizing models. How do we find some other funds to bring in what we are expending for the poor? The last one would be looking for donors who understand us as a organization, whether it be us as a health association, which is a national level, or a small center in the village setup. The capital expenditure for investing in that hospital needs to come from outside. Otherwise, 70% of our institutions rely on, their 75% of their income comes from patient footfall. Reliance on external funding is very little at the facility level. So to bring in the patients, we need to grow. We need to maintain our structures. We need to bring in new technology. We need to bring in new equipment. We need to pay well for our personnel. That is where external funding is important for our institutions and even for us as CMAI. Thank you.
Thank you, Priya. Thank you.
Yeah, if I may add, you are correct in that. And so we do come up with blended finance solutions where we get from the local banks, we draw on other investors who are interested to do that. Yes, that is definitely a way out as well. But again, it's all aimed for eventual self-reliance. Sometimes you have to get the funds to expand necessary capital. Absolutely correct. But that dependence should not be forever. And then you develop a blended finance model that is self-sustaining in itself. And that can be done as well. So there are various ways of accomplishing our goal.
Thank you.
Thank you.
V, go right ahead. Thank you. And I know we have a few.
Thank you. I think looking at FBOs, we are two-pronged. I'm not too sure what's happening in other countries. We have got the other FBOs, which are for profit. We have the other FBOs who are not for profit. So Your operations will be guided in terms of where you belong. But I think our business model, which we should for both, is the values which we bring onto the table, our Christian value. This is what will determine our business model. Because if you look at the situation now, patients of the communities trust the churches. We are easily accessible. We are affordable. Affordable, I'll put it in the bracket because most of the affordability is we can provide services through the financing or donations from our partners, which then allow us to provide quality services. So most people, whether they're urban, they'll be drawn to church institutions because we have most of the resources available for treatment. So, and also we have dignity, we respect our communities. So these are some of the business model where we provide trust and dignity, because churches are trusted. If there's a war and anything, people run to the church. So in terms of operations and moving forward, the question therefore will be, in how do we resource ourselves? How can one invest in faith-based organizations which are not for profit? Yes, we need the donor community, and also because they have an obligation themselves in terms of supporting low-income countries and making sure that people don't suffer. So critical, therefore, is to come up with models which would attract international partners to actually help us to build our capacities, whether it's in infrastructure, in medical equipment, and so forth. But showing that by the end of the day, the people who want to support are those on the ground, where we will then promote the issues of equity, quality of service, and make sure that we have access, people have access to care. So our model, really business model, will make sure that people have access to care and their human rights are addressed as a people.
Thank you so very much, V. This has been truly tremendous, and we're at the top of the hour. I know it seemed like we just ran through this and this was just the beginning, but I wanted to thank everyone for joining us today for this conversation and discussion. And there are quite a few questions we did not get to in the Q&A, and those will certainly be answered. We thank you everyone for joining us. Please ensure to look at the link in the chat box. There is some questions that allow us to receive some feedback from you regarding the webinar itself. We want to thank all of the speakers, all of the panelists who joined us today. We thank you for the interpreters. We thank you for those who've been asking questions and having that conversation in the chat room. Please note that we encourage you to join us for the CCIH conference that is coming up. And I'll say this, my last words. There's so much to share and so much to discuss when we start to talk about the business case for Fbos as it relates to the health systems. Conversations about leadership, conversations about governance, conversations about management, revenue, donor dependency. I think we addressed several of those. Please note that the PowerPoint presentations will also be available for you, and links to further information will be within those as well. Again, to each of our panelists, thank you so very much. We enjoyed your presentations, your thoughts, and your casting forward for what we hope to see for the future. So thank you once again, and everyone have a wonderful rest of your day, your evening, or your night. Take care. Bye-bye.